Welcome back here today, and we're going to begin this afternoon talking about desmoid and soft tissue sarcomas. We have a great faculty today, Dr. Mrinal Gounder from the Memorial Sloan Kettering Cancer Center in New York City, and Dr. Rich Riedel from the Duke Cancer Institute in Durham, North Carolina. We also have Shaker Pelez from the Florida Cancer Specialists in Lake Worth, Florida. So we're going to start out talking about desmoid tumors. And Mrinal, you know, my eyes really got opened a couple years ago when I met you, and we sat down and we were scheduled, I think, to talk for about 2 hours. And I'm like, what are we going to talk about for 2 hours for desmoid? And by the time we were still going at the 2 hours. I learned a lot that day. Before we start getting into the data, and I know this is something, I guess, Shaker, you don't have anybody in your practice with it, but I think you're going to find this interesting. And you can help me pick the brains of the faculty related to that. But just before you even get into your talk today, Mrinal, can you talk a little bit about sort of what desmoid is and why it's different, you know, than the typical kinds of neoplasms that oncologists take care of?
No, sure. Thank you. First, thank you for inviting me to this great program, beautiful location, and stellar topics here. Desmoid tumors are interesting in the sense that these are probably one of the few cancers which about 20% of them can spontaneously regress with no treatment at all. And I think over the years, I mean, you know, we hear rarely for melanoma and renal cell, but this is a unique, and we don't understand why some of these tumors regress.
You call this a cancer. Is it a cancer?
It doesn't metastasize, so in that sense it's not malignant, but it can be locally quite aggressive. It can go through fascial planes, intestinal obstructions, hydronephrosis, lots of pain. These are fibroblastic tumors of the connective tissue.
Rich, what's the typical presentation you see of these patients?
The presentation can be highly varied. It depends in part on where the tumors are located. They can occur anywhere in the body. There's a subset that occur intra-abdominally, and when they do, you need to think about something like FAP. But the symptoms can be fairly nonspecific: nausea, pain, for example. Certainly, if it's in the extremities, you may actually see something or feel something. But the symptoms are fairly nondescript.
And what about the presentation in terms of who develops the disease? Am I right? I think it's more common in women.
There's a slight predisposition to those in women. Sometimes it's associated with trauma, with pregnancy. But mostly the median age is somewhere in the 20s and 30s. So I would say the bulk are young people and a slight predominance towards women.
So we asked you to kind of review where we are today with desmoid tumors. We've really seen a fascinating story that I'm really anxious to hear you talk about how this evolved. But let's talk a little bit about some of the data that we have out there and what we're moving towards in the future.
Sure, happy to. All right, okay. So as we just alluded here, that these are really tumors that can occur anywhere from head to toe and in all age populations. So we can even have infants with desmoid tumor all the way to people in their 80s and 90s. But the peak incidence is really in the 20s and 30s. And as you can see here, intra-abdominal, extremities, paraspinal, head and neck, they're all game. I think the key thing here is, these are really rare. Sarcomas in general are just 1% of all solid tumors. And then desmoid tumors are probably about 10 or 15% of that 1% of all solid tumors. So these are really rare diseases. And the incidence, you can call these rare or ultra rare, but the incidence is maybe 2 to 4 per million individuals. Sometimes they're also known as aggressive fibromatosis or deep type fibromatosis. But the key thing here is that these are fibroblastic tumors that can be locally aggressive, but by definition should not metastasize and do not metastasize. We just talked about this. The incidence is just about 1,000 to in the United States, 1,000 to 1,500 in the United States, and that is what we see globally as well. So I think one of the key things with desmoid tumors in the event that you end up seeing these patients is to make sure that they are evaluated for a colonoscopy. And the reason we say that is about 10 to 15% of desmoid tumors can be associated with FAP. So since and then there are genetic evaluations you can do to determine is this a FAP or a wild type desmoid, and I'll get into that shortly. But I think that's one of the big takeaways is that if we do end up meeting, they need to be evaluated with a colonoscopy or even like a genetic testing. In terms of imaging, the best imaging is really just an MRI or a CT scan. PET scans, ultrasound, all the other modalities have very limited evaluation. So an MRI is probably the most, if the patient can tolerate one, that would be the imaging of choice in this disease. So the driver of these fibroblastic tumors is really beta-catenin or APC. But the bottom line, as you can see in this schematic diagram, is that they all leads to elevated Wnt signaling pathways. So these Wnt signaling pathways, as you know, you can see it in colon cancer, HCC, and so many other solid tumors, but they are buried among dozens of other driver mutations as well as passenger mutations. But we do know that this beta-catenin and the Wnt signaling pathway does have an impact in epithelial tumors, most likely in the microenvironment, and whether tumors respond to immunotherapy or not. But here in desmoid tumors, the bulk of these tumors are driven by beta-catenin, and then a minority of them, about 10 to 15%, by APC in the context of FAP. But ultimately, they lead to elevated beta-catenin and Wnt signaling expression. And as we spoke about before, this is one of the handful of diseases that can spontaneously regress, even after some initial minor progression. And this was studies from the Italian group as well as the French group, both essentially saying that about 20% of these tumors can spontaneously regress, but we do think that some of this may be related to smaller size disease as well as perhaps some associated in the abdominal wall location or in the post-pregnancy state. These are all states where it can, but we don't have a biomarker, we don't have a way to tell who's going to regress and who's going to progress. So it's a little bit of a wait and watch. The key big change in this disease, at least in the last decade or so, is that we've really moved away from surgery. Surgery used to be the mainstay of treatment of desmoid tumors. But what we found is that even with the best of surgeries, the recurrence rates can be as high as 50, 60, 70%. And these things can recur within 3 to 6 months. So surgery has sort of taken a backseat, and a lot of the data was actually generated by surgical oncologists in Europe and now slowly being adopted, but increasingly surgeries has taken a backseat in this disease. In terms of when one should treat, it really comes down to a handful of things. One is there pain? Is there any kind of symptoms, functional impairment? 2, is the disease progressing? 3, is it in a bad anatomical location where if it were to grow further, it would cause say like a bowel obstruction or perforation, hydronephrosis and such. And the last thing is also cosmesis. A lot of these are young people, they could have like a very large tumor, in locations, and it can impact schools, education, employment and such, and also opioid use. So these are all good sort of a ballpark estimate of when one should treat and when one should observe. In terms of the evolution of systemic treatments, before I get into systemic treatments, I also want to say that in a small select group of people, interventional radiology with cryoablation or transarterial chemoembolization could be an option, but because these are involved in really complex locations and fascial planes, it's best to have it be seen at by an interventional radiologist who has some prior experience with this. Sometimes the treatment can be worse than the disease itself, so you have to be cautious about it. In terms of cytotoxic chemotherapies, we have many. Methotrexate, vinorelbine is something that we do, but it's weekly, so it can be quite cumbersome for patients. Liposomal doxorubicin given every 3 to 4 weeks is also very, very well tolerated. We use it quite often. Those are probably the 2 big ones, but generally we try to stay away from just the pure doxorubicin monotherapy or even in combination.
So maybe before you go on, we get into some of the more exciting data in terms of systemic therapy, just to pause a little bit in terms of local therapy. And Rich, Mrinal mentioned cryotherapy. What are the situations where that might be a consideration? Have you seen that successfully used? And what about radiation therapy?
So certainly cryoablation is a very viable option for these patients. You really need to have an interventional radiologist that is skilled with the procedure. Its ability to be used depends in part on where the tumor is, its proximity to skin. You don't want to necrose the skin, for example. In our institution, we will routinely consider it for smaller tumors, typically less than 5 centimeters. There are some that's variable depending on the institution. I would argue radiation therapy has fallen out of favor, in part because you're treating essentially a non-malignant condition with a therapy that can result in secondary malignancies long term. And the disease state itself is not, for the vast majority of patients, not felt to be life-threatening. So at least at our institution, we rarely use radiation. Have I used it, or have I referred patients for consideration? Absolutely, but it's really the rare patient.
And I'm going to ask Shocker if he has any questions, but just kind of continuing on with this. We've had a bunch of cases presented in various CME programs, Mrinal. I know a couple have had breast desmoids where they got surgery, radiation, and then it got referred. And I remember one case where actually it looked like maybe after the surgery they had multifocal desmoid. Does surgery actually make it worse?
It can, and we've never really proven it, but even trauma, surgery, especially in the FAP patients, post-colectomy, is when, in that inflammatory milieu, you could see these desmoid tumors. Usually it's a single solitary mass, but sometimes even multifocal as well.
Also, and I'll come back to you, Rich, how do you take into account the spontaneous regression? Again, I remember one case very vividly. The patient had a very large desmoid that completely went away. How do you decide whether to observe the patient or not?
Dr. Gounder may get to this, but for the vast majority of patients, the initial approach, assuming the disease is in a non-critical location and they have minimal symptoms, is actually to watch it. And I routinely will watch individuals. I'll image every 6 months. I'll watch them for 1 or 2 years just to get a sense of the natural history before I will actually pull the trigger on systemic therapy. Certainly for a disease that's in a critical location, or if they have escalating symptoms, I will consider systemic therapy sooner. But the vast majority of patients we will actually watch because of this issue of spontaneous regression.
Shocker, any thoughts or questions about this? I know this is something that you rarely see. You're kind of in my position when you're hearing about this for the first time. Anything come to mind?
Yes, I'm curious to see what the response rates are like to cytotoxic chemotherapy, and based on the molecular biology pathogenesis, you showed us, how tyrosine kinase inhibitors are going to fare here.
Great question. Here we go. Let's talk about
Perfect, yeah. So I think there has been 3 randomized phase 3 studies that have been conducted. One is with TKI, sorafenib versus placebo, and the other 2 are with this newer class of drugs called gamma secretase inhibitors, and I'll get into that as well. To answer your question in general, whether it's cytotoxic chemotherapy or tyrosine kinase inhibitors, gamma secretase, the response rate is anywhere in the 25% to about 50% ballpark, depending on the class of agents. With the tyrosine kinase inhibitors, the response rate is about 30%. But I'll speak a little bit more to it. The response rate is by RECIST responses. So this is 30% improvement or not. But when you look at the patient-reported outcomes, even patients who don't have a partial response that's counted as a response, even they have a minor response, they still report like a huge improvement in pain, functional status, and such. So we think the RECIST criteria itself doesn't fully lend itself to a disease like this.
Whenever we get into the topic of patient-reported outcomes in general in oncology, I always come back to desmoid because that's so dramatic what you see with these patients.
Indeed, yeah. So there's other tyrosine kinase inhibitors that can also be used, but most often globally as well as in the U.S. We've been using sorafenib, but of course the landscape is shifting here. But Votrient, which is approved in soft tissue sarcomas, can also be utilized here as well. So this is a new class of drugs known as gamma secretase inhibition. They've been in development for nearly 2 decades now, and a lot of the initial enthusiasm with this class of drugs was really in Alzheimer's disease. So a lot of the tau proteins that we see with the myelin deposition goes through the gamma secretase enzymes. And these gamma secretase enzymes are found anywhere from head to toe in neural development, in fibroblastic diseases, in a whole host of different activities. And it turns out that in these, so initially these class of drugs were developed in Alzheimer's. It didn't really quite work out. And then it shifted into solid tumors. There was phase 3 studies and across like many indications, pancreatic cancer primarily. It failed there as well. And then eventually it sort of trickled down into desmoid tumors, and now it has become an FDA-approved drug. So this nirogacestat is the first FDA-approved drug. And to just basically go over the sort of the cell signaling here, is that as I mentioned before, the Wnt signaling pathway as well as the Notch pathway, they both have a lot of crosstalk. And one of the things that downstream of that is the Notch pathway. And the Notch pathway, we think, is inhibited by these gamma secretase inhibitors. So now we have 2 drugs. One of them is FDA approved. The other one just reported a phase 3 study that was also positive. So with this, so the name of the study is called DeFi. This is a global randomized study, 142 patients across North America and Europe, randomized 1:1 in patients with progressive desmoid. And I think we spoke about this, about who are the right people who should be treated. And it's really patients who have progressive disease, who are symptomatic and such. And these were randomized to placebo versus nirogacestat twice daily. And the primary endpoint was PFS, and the PFS for this study was very positive with a hazard ratio of 0.29, which was highly significant compared to placebo. In terms of the benefit, nirogacestat, the PFS benefit was observed across all the endpoints that were previously specified. This included gender, tumor location, prior exposure to chemotherapy, surgeries, radiation, and such. And here's the response rates, as I mentioned before, is that this is the only study where you will see a waterfall plot in this disease, where you'll also see responses in the placebo arm. We never see that in any other study in oncology. So this makes trial design and such quite challenging, but it's an interesting physiology, and we don't fully appreciate or understand what are the immune parameters and others that could induce responses in placebo patients as well. And as I mentioned to you before about the patient-reported outcomes, in a disease where the overall survival is not an important endpoint, the real question is, when tumors do shrink, how exactly are you benefiting the patient? And that's really this is a nice patient-reported outcomes that says that patients who respond, they have significant improvement in their pain, in their sleep, in their functional mobility, and such. So this is a patient-reported outcomes that shows that patients on nirogacestat had a significantly reduced pain and many other patient-reported outcomes parameters. In terms of safety, it's a very well-tolerated drug. It's taken twice daily. Some of the main side effects is really GI, some diarrhea, but mostly grade 1 and grade 2, some nausea. You can have some rash, and it's very well tolerated. And in patients who have some of these side effects, dose reduction still results in excellent disease control in these patients. One of the unexpected side effects of this drug that was only seen in the phase 3 here was ovarian dysfunction. And this was a small number of patients, but most of the patients, the big takeaway here is that even patients, once you stop the drug, women of childbearing potential do recover their fertility. And some patients, even while they're on the drug, they initially have some dysregulation, but eventually recover their reproductive.
So before you go on, another thing I thought was really fascinating about this whole story is I know there was an advocacy group that was very involved in actually this phase 3 study. Can you talk a little bit about that? Because that's one of the few situations I've seen where they really drove this trial.
Absolutely. This is called the Desmoid Tumor Research Foundation. They've been around for 20 years. Started by two women, both of them not in medicine, both of them affected. One spouse was affected by desmoid tumor, the other one personally had desmoid tumor. They went to 4 or 5 different major cancer centers and got 10 different opinions on how to treat. They were so confused. There was very little written in the literature. So 17, 20 years ago, they started this research foundation. And now it's the most dominant sort of a research group that has really brought patients and scientists and researchers into this. So one of the ways they moved this particular drug along is that this drug was basically was abandoned by Pfizer because the phase 3 in pancreas had failed, and they said, we don't know what to do with this drug, we're just going to shelf it. And we had noticed a few patients had responded in the phase 1 and phase 2 with desmoid tumors. So this advocacy group really went after Pfizer for years till it sort of came out of the basement, and then it sort of got a whole new life. And now it's, without them, we would not be talking about these class of drugs at all.
Yeah, really an incredible story. Rich, I know some of the practical issues that come up here. One is how long to treat the patient. And I'm curious, you see patient-reported outcomes really dramatic. I mean, it's amazing. It's placebo-controlled, so it's really for real. But do you see that in treated people? Do they feel better? And any toxicity, we mentioned the ovarian issue, any other sort of quality of life issues that come up?
The issue of duration of therapy for the gamma secretase inhibitors, or to be quite honest, even for our multi-targeted tyrosine kinase inhibitors, is unknown. In the clinical trials, they continue treatment until progression. In clinical practice, we actually routinely will consider taking treatment holidays and still be able to maintain disease control. And so I think that's an area of, it's an area that is unknown currently. At least in my practice, I will tell patients as we start systemic therapy that, particularly for oral therapies, I will consider treatment for a year or so to try to maximize symptoms and or maximize response, and then consider taking a break. There is some data that with re-challenge upon progression, disease can be reestablished. And as Dr. Gounder mentioned, this is typically a younger patient population, so to commit a young patient population to a daily therapy for the rest of their life, it should cause a little bit of pause. So I think that's why we will consider taking treatment holidays, but we don't have robust data around that. Dr. Gounder mentioned the ovarian toxicity. I'll routinely send patients to our fertility clinic to discuss fertility preservation. The data does suggest, however, that if the drug is discontinued, there's a high likelihood for regaining ovarian function, and over 70% of patients who continue on the drug can regain ovarian function. The rash is something that, at least in the clinical trial, seems to be grade 1 or 2 in clinical practice. It's almost like a hidradenitis type rash, and so we will engage our dermatologists and do things like doxycycline, topical steroids, things of that sort. But in my experience, it is a well-tolerated, generally speaking, a well-tolerated medication.
When patients go on a treatment holiday, do they feel different? Are there any symptoms that could go away? Or
it's variable. Some individuals can stay off drug for quite a long period of time, and we will make the decision about retreatment based largely on symptoms. So even if I have an image that's showing some growth, if their pain is controlled, I'll consider watching that. So for me, it's driven by symptoms.
Shocker, any questions?
Yeah, is this something you would consider using as a first line, or is this something that you do after a TKI? How do you compare it to TKI therapy?
From an efficacy perspective, I think all of these drugs are more or less about the same. There are some are slightly better than other, but I really talk to the patients, about convenience of the drug. Do they want to come in once in 3 weeks or 4 weeks to get chemo, like Doxil? Do they want to, do sorafenib once a day or this twice a day? So it really comes down to a lot to, like, some patients are in college, for example, and they don't have the time to come in for chemo, so they prefer an oral. So it really varies quite a bit. From an efficacy perspective, I think some of these newer drugs are better and maybe more well-tolerated, but they're all sort of in the similar ballpark. So
it looks like we have another positive phase 3 trial.
Yeah, so this was also similar to the Pfizer drug, the nirogacestat. It's a BMS drug that They were also pursuing it in many other solid tumors. Ultimately didn't work out, and this got sort of bought over by a smaller company that then led the second phase 3 study in desmoid tumors. This is known as Ringside. The name of this compound is called varegacestat. This is also a gamma secretase inhibitor. This is the trial design is a copy paste from the previous protocol, so there's really no change at all. Again, about 150 patients randomized 1:1, and this data just came out, very positive, with patients treated on varegacestat having an 84% reduction in the risk of progression or death versus placebo. Hazard ratio 0.16, very, very significant. And here you see the response rate with varegacestat is about 56%. So this is one of the highest we've seen so far, but I think a lot of the other drugs do well as well. And in terms of not only decreases the RECIST dimensions, but also the volume as well. So here you'll see that 83% sort of volume reduction in patients on the treatment arm compared to 11% growth in the placebo arm by volume. I think, and this is the last slide, I think the key thing is for both Rich and I, like all we do is just deal with soft tissue and bone sarcomas. We see a lot of desmoid tumors, and every week in our tumor board, all of us collectively struggle with every single patient in terms of what's the best thing to do. This is really a difficult disease, not just desmoid tumors, but all soft tissue sarcomas. There are 50, 60 different diseases all lumped into one umbrella term called sarcomas. We struggle with diagnosis. Even at a major center like ours, we have 4 sarcoma pathologists, and every week we're going back and forth deciding what exactly is it, and which does have a huge implication in terms of how to treat the patients, clinical trial eligibility. So this is a tough disease. Like I've been doing this for 17, 18 years and still struggle with a lot of the nuances. And there's so much emerging data from molecular perspective. So I think at least if you are facing a soft tissue sarcoma patient for the first time, I think having them see sort of a tertiary care sarcoma center for diagnosis, and then even if they get treated locally, that works. But I think this is quite a challenging disease to deal with.
Yeah, I love talking to sarcoma people. It's like Talmudic school of sarcomas. There's so much to talk about. Rich, I guess this new agent, it's new varegacestat, going to be presented at ASCO, this phase 3 study. Any thoughts on how you're going to decide between that and nirogacestat?
I'm probably going to punt the question because we actually haven't seen the full data set yet. But I think, as Dr. Gounder pointed out, the response rates are really encouraging. The PFS is impressive. I think it just speaks to the fact that gamma secretase inhibitors as a class of medications are highly active in this disease. We have now 2, we hopefully will have 2 FDA-approved agents in the coming year, and I think in the end, it's going to be providers' experience with each agent, a balance for the side effect profiles between the agents. It's actually a good problem to have. But I think it's a little premature until we see the full data set, until we see the peer review publication.
Do you know whether or not you see ovarian suppression, Mrinal?
Yeah,
with both of them?
This is a class effect. So it's a class effect, so we see it in both.
And it's a direct effect on the ovary?
It's a direct effect on the ovarian granulosa cells or something. Yeah.
All right, well, let's move on now and talk about soft tissue sarcoma, some interesting treatment there to talk about. Rich?
Great, thank you. Thanks for sticking around, coming back after lunch. We ate as well, so we're also trying to stay awake. As was mentioned, I'm Rich Riedel from the Duke Cancer Institute, and we're going to broaden the scope a little bit here and talk about soft tissue sarcomas. Disclosures are shown here, and there were about 8 objectives or so in your handbook. I've distilled them down to the 4 listed here. I'm going to talk about the historical treatment for soft tissue sarcomas. I'm going to specifically focus on the treatment of an ultra-rare sarcoma known as PCOMA, or malignant PCOMA. I'll talk about some evolving data regarding the use of cell-based therapies in 2 other histologic subtypes of sarcoma, and then end just with a summary of some other novel approaches. So here's the problem. Sarcomas are rare. They represent 1% of cancers in adults. In this year, about 15,000 individuals would be diagnosed with a sarcoma, and as you are all aware, that's in stark contrast to things like lung, breast, colon, or prostate, where we have hundreds of thousands of individuals diagnosed a year. Dr. Gounder mentioned there are more than 50 different histological subtypes. Each year we seem to have a new entity that's described. So I routinely will tell patients, right or wrong, that there are more than 100 histologic subtypes. They can occur anywhere on the body, from the tip of the head to the tip of the toe, and they can affect soft tissue or bone. And shown on the right are just some representative examples. Here are some of the challenges that we have. We're limited by the rarity of the disease. There is marked heterogeneity, both in terms of genetic diversity, molecular diversity, histologic diversity. Patients who have metastatic disease have a poor prognosis. Our systemic therapies are limited in number. They're limited in their effectiveness. And to be quite honest, they historically have been toxic. So we're in desperate need of novel therapies. This is sort of how my practice has evolved. Prior to 2012, the vast majority of sarcomas for whom cytotoxic chemotherapy was appropriate would get an anthracycline in the front line, and we would ask really stimulating questions like, should we give it by itself? Or should we give it in combination with something else? We had some emerging data to suggest that there were histologic subtypes that could preferentially respond to specific therapies. For example, paclitaxel and angiosarcoma, for example. Gemcitabine-based regimens came into vogue in the mid-2000s. We had some oldies but goodies like ifosfamide and dacarbazine. And you can see as we moved into the 2010s, we had some new agents highlighted in bold that were FDA approved. Trabectedin, approved in lipo and leiomyosarcoma. Eribulin, approved in liposarcoma. Pazopanib, approved for a broad range of non-lipomatous sarcomas. And one of the reasons why we've made advances is because we've sort of changed the paradigm, moving from a one-size-fits-all clinical trial that would enroll all histologic subtypes now to doing histology-specific clinical trials. And since 2019, we've had now close to 10, if not 10, FDA approvals. You can see them listed here: tenosynovial giant cell tumor, GIST, PEComa, which we will talk about, alveolar soft part sarcoma with the approval of atezolizumab, the only immunotherapy currently approved in sarcoma, and others listed. So we've made significant advances just by the way that we do our clinical trials and understanding the underlying biology of the disease state. For this talk, we're just going to focus on these three here. We're going to talk about the use of nab-sirolimus in malignant PEComa, and then I'll talk about some developing engineered T-cell receptor strategies or cell-based therapies, specifically in synovial sarcoma and myxoid round cell liposarcoma. So let's start with nab-sirolimus in malignant PEComa. So who's seen a PEComa in this room, if anybody? Great. It's actually more than I anticipated. So PEComa is an ultra-rare sarcoma. It's actually a family of mesenchymal tumors. There are less aggressive or benign types like LAM, for example, or angiomyolipoma of the kidney. And then there are the more aggressive or malignant types like malignant PEComa. It has a female predominance. It can occur anywhere in the body. Most commonly, we'll see it in the uterus, in the kidney, for example, but certainly can occur in other sites. And we're challenged because this is an entity that historically has not responded to cytotoxic chemotherapy. And so we were really challenged with this disease. What we learned, however, again, understanding the underlying biology of this disease state, is that these tumors would have mutations in TSC1 or TSC2, which would result in activation of the mTOR pathway. And we had anecdotal reports and case series supporting the use of mTOR inhibition as a therapeutic approach. Well, the AMPECT study came along. This was looking at a novel formulation of sirolimus, in this case a nanoparticle albumin-bound version of sirolimus. This was a single-arm phase 2 study for patients with unresectable or metastatic PEComa. Everybody received nab-sirolimus, and you can see on the far right the primary endpoint was response. Secondary endpoints included progression-free overall survival and duration of response. Some patient characteristics: small study, 34 patients. That's actually really good for us for an ultra-rare histology. 34 patients, the majority were female, the majority were Caucasian, the majority had a good performance status. And here are the primary endpoints: response rates approaching 40%, disease control rate in excess of 70%, median PFS in excess of 10 months, median OS in excess of 50 months. This is quite impressive from considering where we came from, a disease state for which chemotherapy just did not work. Shown here is the waterfall plot. You can see the vast majority of patients had some target reduction. Everything under the dotted line is either partial or complete response. And then when we look at side effects here, the number of grade 3 adverse events here are quite minimal, led by anemia and mucositis, which are known side effects with mTOR inhibition. But you can see across the board here the side effects: mucositis, rash, diarrhea, cholesterol effects, for example, all consistent with what we know already from mTOR inhibition. So this is an important study. It's an important study because it really confirmed prospectively the strategy of using mTOR inhibition in malignant PEComa, specifically the use of nab-sirolimus. And importantly, efficacy was shown and no new safety signals were observed. And this actually led to FDA approval in November of 21, and for me and patients with malignant PEComa has been a game changer and certainly something that has moved the field forward. I'm going to transition and talk about some emerging data regarding cell-based therapies. For any of you who deal with malignant hematologic conditions, you're familiar with the CAR T story. Well, the idea of engineered T-cell based strategies in solid tumors is really being led in the sarcoma community. I'm going to specifically comment on synovial sarcoma and myxoid round cell sarcoma. These are two histologic subtypes of sarcoma. They account for somewhere between 5 to 10% of all soft tissue sarcomas, probably less than 1,000 cases a year of each. These are what are referred to as translocation-associated sarcomas. Synovial sarcoma has an X18 translocation. Myxoid round cell has a translocation between chromosomes 12 and 16. But importantly, what we've learned is that both of these tumors express tumor-associated antigens, specifically MAGE-A4 and NY-ESO. And so the question is, can we effectively target that for therapeutic gain? So just to briefly review, for these T-cell receptor products, it follows a similar paradigm to what we do for CAR T. So going counterclockwise around the circle here, after patients are confirmed to have an HLA, the appropriate HLA type, and showing appropriate tumor expression of the antigen, the patients undergo leukapheresis with collection of T cells. Those T cells are then engineered to target the antigen of choice. They are amplified and then infused back into the patient after receiving lymphodepleting chemotherapy. So this was studied in the Spearhead 1 trial. This is looking at what we will call afami-cel, specifically in synovial and myxoid round cell liposarcoma. This was an open-label phase 2 study. The study enrolled 52 patients. 44 were synovial sarcoma, 8 were myxoid round cell liposarcoma. I'm showing the data for synovial sarcoma here. Again, a younger patient population, median age around 40. Equal representation between men and women, good performance status, and the vast majority of patients, the majority of the patients had more than 2 lines of systemic therapy with progression. Shown here is the waterfall plot. We love to see this. Again, the vast majority had some reduction in target volume, but the overall response rate for the entire study here was 37%, 39% for those with synovial sarcoma, 25% for those with myxoid round cell liposarcoma, and I would argue this is better than any cytotoxic chemotherapy that we have for this disease state currently. For those individuals who had responses, the responses were durable, as shown by the spider plot shown here. And those who had response, the blue line, upper blue line for the Kaplan-Meier curve, they did better than those who did not have responses, shown by the purple line on the bottom. Subgroup analyses, they looked at antigen expression, sex, age, lines of therapy, and you can see across the board responses were seen regardless of the clinical subgroup that was analyzed. So a highly effective, efficacious therapy here. In terms of side effects, the side effects are not unexpected for the type of therapy that we're dealing with. We see hematologic toxicities with cytopenias, in part largely due to the lymphodepleting therapy. We see things like cytokine release syndrome related to the actual cellular product.
How much of an issue is cytokine release syndrome?
I would say the vast majority of patients, as shown on the slide, the vast majority actually experience it. Generally speaking, I think we our malignant hematology colleagues are used to dealing with it. We're learning about it on the solid tumor side. So at least currently at our institution, we partner with our malignant heme folks, so they deal with that, at least for the first 30 days post, and then they send them back to me.
These people get tocilizumab?
Mm-hmm. They can, if they need it, for sure. Yeah. So Spearhead 1 really showed that using an engineered T-cell approach that specifically targets MAGE-A4 is feasible. It has efficacy. Importantly, these patients have an HLA restriction and HLA-O2 genotype, but impressive response rates, approaching 40% for synovial sarcoma with a reasonable side effect profile. And this was FDA approved in August of 24, and there are a number of centers that are being opened around the country that are approved to give this therapy. On the heels of this approach, we have the IGNITE-ESO study, same strategy, looking at an engineered T-cell product, but this time targeting NY-ESO, another one of these tumor antigens. This study was an open-label phase 2. It was presented at our sarcoma meeting by Dr. Gounder's partner, Dr. Sandra D'Angelo. This was an open-label phase 2, 64 patients equally split between synovial sarcoma and myxoid round cell. On the right, same strategy, lymphodepletion, apheresis, engineering of the cell product, lymphodepletion, infusion of the cell product. And the primary endpoint here was response. Again, a very impressive waterfall plot. Response rate's 42%. If you look in the table on the bottom, it was 42% for overall, 41% for synovial sarcoma, 43% for myxoid round cell liposarcoma. So both histologic subtypes with the response. Similar to what we saw with the prior study, again, toxicities largely hematologic due to lymphodepleting chemotherapy, and things like cytokine release syndrome and rash related to the cell product. So I think the IGNITE-ESO, again, showed the feasibility of targeting NY-ESO as a tumor antigen, again, in an HLA-restricted genotype of patients. Response rates in excess of 40%. Responses were durable with a reasonable side effect profile. This will be submitted or has been submitted to the FDA for consideration, and I think everyone is hopeful that this will be the next FDA-approved cell product for sarcoma.
Naive question, like how would you compare this to doing CAR T? It sounds like CAR T.
I think the process is very similar, if not the same.
And it's a one and done?
Correct. Just in closing, we're making advances in other histologic subtypes. A couple of years ago in the New England Journal, we had the publication of atezolizumab, an anti-PD-L1 monoclonal antibody specifically for alveolar soft part sarcoma based on a response rate approaching 40%. More recently, we've had doxorubicin in combination with trabectedin showing improved progression-free and overall survival in patients with leiomyosarcoma when compared to doxorubicin alone. At our sarcoma meeting in November this past year, we learned about a death receptor 5 agonist in conventional chondrosarcoma, a disease state which has no known effective therapy. And at ASCO this year, we're going to hear about the PEAK study, which is looking at a combination of TKIs and GIST. For those of you who treat the disease, you will know that for 25 years we have used sequential single-agent therapy. This is the first study that has shown a rational combination with bezuclistinib and sunitinib that showed improved outcomes when compared to sunitinib alone. And then we have some ongoing strategies. Through our cooperative group, we're looking at adding a checkpoint inhibition to frontline anthracycline therapy, specifically in UPS and liposarcoma. We're looking at IDH1 inhibition, specifically in chondrosarcoma. About 40% of patients will have IDH1 mutations. We're looking at novel strategies like intratumoral injections through the Invincible-3 study. And we're starting to dip our toe into the water of using metabolic approaches, in this case an arginine depleter in combination with chemotherapy, specifically in patients with leiomyosarcoma. So I think there's a lot of excitement about what's happening in the field. Our treatment landscape is rapidly growing. We're clearly making advances with, as I mentioned, 10 approvals since 2019, including approvals in rare histologic subtypes. And sarcoma is leading the way among solid tumors with engineered T-cell receptor products. So I would argue that the future is bright, and I'm hopeful that 5 years from now we're treating this dreaded disease very differently than we have been for the past 50.
So we've got a couple interesting cases, but first I'm curious, Rich, my group here pulled out, I don't know if it's really plenary, it's hard to believe, but SARCO-4-1 coming up at ASCO, phase 3 randomized double-blind study of abemaciclib versus placebo in patients with advanced dedifferentiated liposarcoma. Any comment?
Sure. So this data, the use of abemaciclib is a CDK4/6 inhibitor, and we know that dedifferentiated liposarcomas have CDK4 amplification as well as MDM2 amplification. And all of this data originated at Memorial Sloan Kettering with Dr. Gounder's partner in crime, Mark Dixon. And so this is looking at sort of a next generation therapy. The fact that it's made the plenary session is a big deal. Sarcoma has been on the plenary session 3 times since 2000. Once for GIST in 2002, once for a phase 3 study that actually turned out to be negative, resulting in removal of FDA approval of a drug, and now the PEAK study. So a lot of enthusiasm. I think we're hopeful for this, but I think there's a lot of excitement about this, specifically in DDIF lipo.
Interesting. So, Mrinal, a couple of cases here is pretty similar of desmoid from the audience. One, 36-year-old woman, 15-centimeter intra-abdominal mass, biopsy desmoid wrapped around the mesentery, intermittent pain. How should the patient be treated? Another case, 35 oh no, that's here it is. Here's the other one. The other one's 19-year-old woman, pelvic desmoid, 4 years ago, maintained on sorafenib initially, but stopped due to side effects, especially fatigue with low doses. Now with progression with a very large pelvic mass. How would you treat? Would you use egg retrieval?
Yeah, so earlier we spoke about this active surveillance. These are patients whose tumors are unlikely to regress spontaneously. If female gender is young age, bad location, these tumors don't regress. Plus the size is also 15 centimeters or so. In the first case, with the large tumor wrapped around in the mesentery, there's any number of approaches. I think the gamma secretase inhibitors are great. The nirogacestat is FDA approved, as long as the patient doesn't have too many GI side effects from the mesenteric involvement. It's a very reasonable drug to give. Sorafenib is reasonable, and so is chemotherapy. It really comes down to patient preference and other comorbid conditions to decide which one of these 3 options are good. In the second situation where the patient previously was on sorafenib for many years and then taken off and now progressing again, reasonable to go back to sorafenib. And the doses we use, unlike HCC, we can get away with 400 milligrams once a day or even 200 milligrams once a day and occasionally 200 milligrams every other day as well. These tumors still can respond even at very low doses with excellent quality of life. So you can always re-challenge this patient as long as their quality of life, they tolerated the drug well, or any of the newer agents, gamma secretase inhibitor, nirogacestat, or methotrexate, vinorelbine, or liposomal doxorubicin are all very reasonable options to present.
So, Rich, have you seen intra-abdominal complications in terms of wrapping around the mesentery?
Unfortunately, I have. I actually have an individual who's in the hospital currently for these complications. So this is particularly troublesome for individuals with FAP, where many of the time, a majority of the time, I think the desmoid tumors occur in the mesentery and can be multifocal. This is probably the one situation in which desmoid tumors can be associated with mortality, or FAP-associated desmoid tumors in the mesentery. So unfortunately, we do see complications. But again, with the introduction of gamma secretase inhibitors, I think we're definitely moving the needle and providing benefit for these patients.
Shocker, any questions?
So we know CAR T-cell therapy is curative in lymphoma. We're talking about it curing myeloma. Is it curative in these soft tissue sarcomas? You had some CRs, and the overall survival curve looked really flat for the responders.
Rich?
I think the data is early. We don't have long-term follow-up for these patients. I would love to say that we have the potential to provide a cure for these patients. I think the proof is in the pudding, and we will see. I do have patients who have received the engineered T-cell receptor product who have had complete responses, and they're durable. But it still causes pause for me when we're talking about patients who were metastatic to begin with.
All right, we'll squeeze in one more quick case for you, Mrinal. 35-year-old woman presents with metastatic alveolar soft part sarcoma, small bilateral pulmonary nodules confirmed by biopsy. What's your initial approach for this patient? Is there a role for observation before you start systemic therapy? What about conventional cytotoxic therapy? What's your initial treatment choice in a situation like this?
I mean, there's no exact right or wrong answer, but I think observation is unlikely to help, but if it's a small volume lung disease, there may even be a role for surgical resection for a potential cure. So this is, in sarcomas, even with metastatic lung nodules, if the nodules are small and limited, there is a role for resection for a potential cure, but it really depends on the timing of it. In a patient with ASPS, I think right now with the FDA approval of atezolizumab, I think it's very reasonable to start. Sometimes I think it's a good place to start. But are there a role for chemotherapies? Alveolar sarcoma doesn't really respond very well to cytotoxic chemotherapies. Occasionally, when it's very aggressive and it's growing fast, we do sort of desperately try to use different cytotoxic. But I think the immunotherapy approach, as well as tyrosine kinase inhibitors as well, there is a role for both of those in this disease, particularly crizotinib and other MET inhibitors.
All right, we're going to move on. Thank you so much.
Thank you.